Hello and welcome back to Yodo. I'm Dr. Sarah Bohm. Because of some questions that I got from some learners that I interact with at work, I'm going to provide some additional information regarding some methods that we use to navigate difficult conversations. In this video, I'm going to provide more data, information, theories about how to communicate with someone that has serious illness and navigating these tough conversations. Needing to speak with an individual about their illness, their goals of care, choices for life-sustaining treatments is very stressful for anyone, but especially stressful for a young physician or nurse practitioner. Becoming successful at guiding these conversations includes understanding several principles of human behavior as well as applying specific approaches during these meetings, and we want to remain alert to the verbal and nonverbal information and communication that's going on. Being flexible and adaptable to the needs and concerns of the person and their loved ones is going to aid in having a successful dialogue rather than just a frightening monologue. We do practice scripting to help young physicians and learners to become more accustomed to the word combinations. We start by framing the conversation with the person and their family so that they understand what our purpose is. We like to let them know what we plan to cover and try to elicit permission to proceed with the conversation. I want to point out that people who allow us to provide honest information are very brave to hear it. It's courageous for a person to learn about their illness and trajectory, and is bold to make choices. It takes tremendous strength to hold fast to the quality of life and face potential future that may include decline. We want patients to feel supported and accompanied in their journey, and we will provide them what they need to choose for themselves what fits their beliefs and lifestyle best. Finding inner peace and reaching goals while experiencing loss and enduring suffering can be obtained when important information is given and decisions are made ahead of time. We want to address things in a timely manner. Today I will talk about a couple of theories behind some of the principles that we use, a few do's and don'ts, and I'm going to review some additional suggestions for these difficult conversations as well as some statements that we use. Because of the critical nature of these discussions, learning techniques on how to approach an uncomfortable topic is something that I think every healthcare provider of every discipline should be taught. This line of communication is typically problematic for everyone involved. Something that I tell the learners that shadow us on our team is that it's a normal response to be uncomfortable. Admitting that we're uncomfortable can be used as an icebreaker as well. I've not yet encountered a person that did not appreciate me being human and having feelings as well. Everyone wants to have good health, and to be told that return to good health, or worse news, returning to independent living, is not likely, or terrible news such as life expectancy is limited, puts the person as well as the provider in an awkward state. Patients knowing that their clinician is troubled by the news shows that we're sensitive and that we're also wanting to be approachable. So telling someone that they likely are going to need more help, that they may need a different living environment, those thoughts and comments have profound implications well beyond a spoken word. So just how do we do this? One of the mnemonics that we use is SPIKES, S-P-I-K-E-S, and it reminds us of some commonly used approaches. And the S is for setting, P, perception, I, invitation, K, knowledge, E is emotion, and S is for strategy and summary. We want the setting to be as optimal as we can provide for. We want to determine what's already believed or known by the person, and we request their permission to proceed with providing them that information. We want to build rapport by learning about the person as an individual, so hopefully they're going to allow us to provide honest information. We don't want to overload them, but we do want to provide true data that's sensitive and provided in a timely manner. And it's a big part of that communication process for this back and forth communication between us and the person. We then want to allow the person to process that information, and we're going to use pauses in our conversation because emotions are to be expected, and we want to allow the emotions to be expressed. We want to accept them and name the emotion so that we can support the person. We use various strategies in our process. There's different steps that we use, different points in the conversation, and we try to give the truthful information in a compassionate and empathetic manner. We avoid drowning people with numbers, and we want to use less complicated medical jargon, because all of this can overload the person and cause them to just shut down. So we have to remain sensitive to the dynamics of the communication. We're going to monitor both verbal and nonverbal cues. Sometimes it might be the body language of the patient and their family that's going to inform us how that communication is being received. When we conclude, we're going to briefly summarize what's been shared by both sides, and that's going to help ensure that the essence of the discussion was grasped by everyone. Questions need to be addressed and need to be answered if either side has questions. Patients need this critical information to make their own decisions about their health, and they should be allowed and encouraged to make their own decisions about their own health. In the hospital setting, another service has placed a consult for palliative medicine, and they provide us with a little bit of data about what's happening with the patient, and we do a thorough chart review. The palliative discipline can assist with helping them manage and care for the patient. Before the meeting with that patient and their family, we're going to communicate with any other medical services that are also involved because we want to have relevant information. Patients might have already discussed their illness and their choices regarding whether it's their care, their living circumstances, or maybe even their life-sustaining treatment choices. They may have discussed that with one of the other services, so we want to gather that information. We want to reduce uncomfortable feelings that are going to accompany having a talk about these topics. We're going to invest time that's needed to learn the patient's story. We want them to provide us insight and knowledge about how we can assist them and what recommendations we can make for their particular situation. We're going to build a relationship based on understanding the person as well as their illness. And in an inpatient setting, we may not have a very great environment and our time might be limited. Hospitalized patients are often very sick. They may be in a shared room. They could even be critically ill and in the ICU. And sometimes there's just not much privacy and there may be a lot of noise. The outpatient setting we also get consulted for, and this is a lot different, but similar in many ways. Patients are typically not as ill. They are certainly having a serious illness, but maybe not in crisis. So the stress level is typically lower and the time is not so crucial. The patient may be frail, have serious illness that's causing them to have symptoms. Maybe they were recently in the hospital, but often they're medically stable. It's likely that this person has pain or they want to have some symptom managed better, or they're trying to learn about services that are available to them. We may be consulted by surgery service because they've got a patient that's a high risk and they want to offer them a surgical intervention, and they want to make sure that that person has had a consult with palliative medicine to talk about not just their outcomes and if those outcomes are going to be suitable for them, but also what are the life-sustaining treatment choices. Surgery likes for us not only to talk about their illness and the intervention, but they also like us to address prognosis and trajectory of the patient. In the clinic setting, we're going to use a lot of the same principles of communication that we use in the inpatient. But again, as the stakes aren't quite so high, it's not quite so uncomfortable for everybody. In both the inpatient and outpatient settings, our approach is going to be a little bit similar. We're going to introduce ourselves, talk about our purpose. We're going to ask the patient to allow us to change roles with them during the process of the discussion to allow both of us to be the student and both of us to be the teacher at different times. We're going to give background on our service and what we do. We're going to talk with them about the symptoms that they're having so that we can provide suggestions to the primary service that's managing their care. We're also going to review the disease state and stage, and if they've got more than one disease, we'll review each one of those. If allowed, we're going to speak to their prognosis and trajectory as well as review what the other services that the patient might benefit from receiving. Palliative care makes every effort to connect with the patient and their family by learning about them as individuals. The introduction of ourselves is often followed by requesting the patient, as well as those in the room with them, to introduce themselves. We want to learn about the patient's social, family, work history, health history during our introduction. We're going to gather quite a bit of information during this introduction. There are people that even with all these efforts that are reluctant to give these difficult conversations a little bit of time and a little bit of effort, regardless of the setting. Common reactions that can be encountered that'll shut a person down could be anger, denial, disbelief, resentment, suspicion, or even humiliation. A person might feel pressured or even bullied. Some patients might feel like they're being ganged up on, or that people are giving up on them. And we do all that we can to recognize and mitigate those negative emotions. If these situations are developing, we want to diffuse those early. To learn more about those emotions behind that, we're going to take a minute as a sidebar, and we're going to talk about Maslow's hierarchy of needs. Let's introduce Maslow's hierarchy of needs. The psychological theory categorizes human needs into 5 different levels, and hearing the hierarchy can give that aha moment of understanding, so we're not really going to go into much depth here. Physiologic needs covers the person's basic survival needs: food, water, air, and sleep. Those are our biggest priorities. Then the need for safety, resources, safety of family, safety of home and work. And when those are met, the patient can move to the next level, which is love and belongingness. And this is all about their relationships: family, biological or chosen, home, friends, and community. Next is the importance of self-esteem, self-confidence, achievement, and a sense of self-respect. When all of these have been addressed, self-actualization is enabled. And this is self-fulfillment and personal potential realization. The hidden importance of this is that addressing the higher level of concerns is really difficult until after those basic needs have been ensured. The medical team will acknowledge and address that these physiologic needs can be important for a patient, and we have to address them pretty much in order. But also be mindful that a stressed patient, it may not follow the typical pattern. And so we keep these principles in mind, but know that there's going to be some fluctuation with them. Having needs addressed appropriately is going to help that patient move forward. And we want to provide the patient with important information so that they can make the decisions that are necessary for them to have the quality of life that they want. Giving attention to a patient's thoughts and feelings is accomplished by asking these open-ended questions and learning about them as an individual. We want to show sincerity, and we want to be able to support them as an entire person, as a whole patient, and not as an individual with a disease process. And there is a little bit of a difference there. Having these conversations is as important as caring for the medical condition. Each of these plays a role in the person's health and life journey. To give a little bit more perspective, let's consider the Herth Hope Index. These 12 questions help us understand concepts, then provide more insight into direction of asking questions to a patient. These are about a patient's outlook toward life and even in-look toward themselves. Do they have short and long-term range goals? Do they feel alone? Have they the ability to see possibilities even though they are currently experiencing difficulties? Do they have a faith that provides them comfort? What about being scared for their future? Is their ability to recall happy and joyful times still intact? Do they have a sense of inner strength? How about feelings that they're able to give and receive care and love? What is their sense of direction with their life? Do they maintain a belief that each day has potential? And are they assured that their life has value and worth? We use the concepts of these questions when we address patients. We want to allow the conversation to develop naturally, and we want that discussion to be fluid. No two discussions are the same. These concepts are all very helpful in our communication with patients and families. Using principles will guide us to have a more successful conversation, as well as those open-ended questions that I talk so highly of. We don't want to ask questions in a way that implies we have judgment. We don't want the family to feel that they're on a defense. And so typical starting place is going to be to ask the person what they want us to know about them. And that's going to provide valuable bits of key information for us to build upon later. We're going to inquire what's been happening to their health, what they understand about their illness, and their prognosis. We want to find out what they know and what they believe that they know, and ask if they're going to want us to include someone else in this discussion. Sometimes patients will refer us to someone else. They'll tell us about them and give us that introduction, but when it's time for news to be given, they'll tell us they don't want to hear their own bad news and they'd rather us tell someone else. And that's fine. We learn about their important goals, fears, worries, and we also want to know what trade-offs or sacrifices they might be willing to make. We want to gently learn if there's an invisible line that's not to be crossed in the quest for more time. Again, we don't want to influence a person's responses by leading statements such as, "You don't want that, do you?" or "You do want something else, don't you?" A better way to explore a response might be, "Tell me why you want that. Help me understand better." Check me if I have this right. What I think I'm hearing you say is. We want to let the patient know that we have understood their goals. And ensuring that a patient grasps our information is equally as important. We want to verify that they have understanding of the methods, outcomes of treatments, procedures, medications, or surgeries that might be offered to them. During that summarization process, we're going to confirm that we have an accurate understanding of each other and then clarify any questions that people still have. Another technique that we're going to use has to do with understanding that patient by understanding their narrative. Narrative medicine plays an important role in palliative care. The concept of narrative medicine is a beautiful one, as it helps us understand the person. The use of narrative medicine is common as we gather stories from the person regarding key events in their life that have occurred that help shape their life and impact their value system. Having insight into a person's belief provides necessary information to allow us to provide them suggestions and offer recommendations at important crossroads of their health. Asking these few simple open-ended questions can really give us a lot of enlightenment and can help them guide them to their own decisions. The response to each question will help guide us to the next question. By demonstrating to a person that we have gathered a deeper understanding of them shows that we're actively listening to them. We've learned what their needs, fears, preferences, and hopes are, and that's going to help us build that rapport that we so desperately need to build with the patient. Asking that simple opening line of what do you want us to know about you can certainly give us a lot of information about a person. Exploring these life experiences that have shaped their beliefs and values allows us to provide them that individual guidance. And we need this information to help them develop attainable goals that are tailored specifically to them. We want them to have achievements and have success in reaching those goals because that's going to help promote inner peace by giving them the feelings of accomplishment. There are barriers, there are fears to these conversations. Some patients want to wait on making decisions. They hear recommendations and it doesn't provide them the answers that they want, or they may admit that they feel like they're stuck waiting on someone or something. They may tell us, I'm not real sure about what's going on. I know I have a problem, but I'm waiting on another test. I'm hoping to get into a clinical trial. I think there's a new medication, and I might be a candidate for that. So we want to ensure that the patient has assistance to guide them through that maze of healthcare. Sometimes it can certainly seem like there's endless tests, and there's always a search for something more. Along the path of declining health, doctors, hospitals, tests, and medications sometimes get in our way along the quest to regain health. We might even lose the sight of the person that has the illness. Understanding what they enjoy and how we can reduce suffering gives that person back their own dignity and themselves, and it can show that we respect their value systems and their personal priorities. Hearing how their life has been turned upside down and what it's changed from and what it looks like now is heartbreaking. When a patient has been provided opportunity to share with us what they would like for their life to look like, given the circumstances that they are suffering from, it helps them regain control because we're allowing them to understand more about their illness and understand that they do have choices. Our goal is to empower the patient to retake the control of their health. We want to enable patients to have hope. Hope needs to be present in all circumstances, and it needs to be allowed to change over time. Hope has its own life. Sometimes hope might seem more like a dream, and working toward it can be something that you can achieve. Other hopes are more like wishes, and they're out of our control. Examples of some of these might be hoping for a miracle, hoping for a cure, hoping to feel better, hoping for pain to be managed, hoping to be active again, hoping to regain strength, to not to get worse, to maintain control of themselves, regain control of their health, helping a family member, helping themselves. They have hope to remain independent. And for those at the end of life, they may have hope to be remembered well. They maybe want to reach a personal goal, a birthday or an anniversary or a holiday. They might want to finish reading or writing a book. Maybe they need to mend a fence with a loved one, or they want to give a few more of life's lessons to a loved one, but they want to leave a legacy. So all of these are different kinds of hopes, and some are achievable and some may be less likely to be achievable. Because of the breadth of the concerns that palliative medicine covers, our service includes highly trained mental health and spiritual experts. Even with the best efforts of each of the disciplines, sometimes patients may make statements that demonstrate poor understanding from a prior discussion or a current discussion. They may say something like, "I didn't know I had these choices. If I'd have known that this might have happened, I would have chosen something different. This wasn't worth the sacrifices that I have made all along the way, and now it's affected my quality of life." Common fears that a patient may share could include, "I fear not being told the truth. I fear being told the truth. I'm suffering from an unmanaged symptom, and I'm afraid of shortness of breath getting worse, or my pain not being able to be controlled." Some patients might be concerned about being alone or hurting a family member. They don't want to leave their family behind, or they're afraid to leave. Some are concerned about finances. They may have concerns about the dying process itself, and sometimes patients have concerns about what comes after the dying process. I'm sure each of you can think of many more. Some typical causes of poor discussion progress include a poorly prepared medical team, a patient or family that's not willing to have an open discussion and will shut things down. Statements that might imply the discussion is not going to progress might be, "This has happened before. We're counting on a miracle. I don't want to give up. We will keep on fighting. I don't believe there isn't more treatment somewhere else. Everyone is just giving up on me." There's significant fear of abandonment or lack of care from some patients. This is a really common problem, and it really needs to be addressed to reassure the patient that they're not going to be abandoned. Another common issue that can stall things out is when memory issues are a problem. Indecision is a big barrier, and sometimes patients don't realize it, but when they don't make a choice, even though choices may be presented to them, they don't like the choices, so they prefer to wait. I try to remind them that indecision is a decision. There's a window of time for any particular opportunity, and if we wait too long, that window may close. This can be a huge sticking point for some patients, and they may not overcome that barrier in time. Other statements we rely on include, "Let me see if I have this right. I want to know more. You're important, and I want to hear what you value. I understand that you have had health problems in the past, and each time you've been able to go to the hospital and you've come out and eventually done okay. But it sounds like you're in a different place now. I don't know the best way to tell you, but I'm very worried about you. What I see happening is, I feel that it's really important to tell you some truths about your health. I cannot ignore what's happening." An easy yet very powerful statement starts with, "I wish." And that often is followed with our concern. "I wish I had better news." Phrases that we avoid, "at least," that's a terrible one to use. "Doing everything possible," it really doesn't address the concerns for the sacrifices that the patient's making. "Removing care," it makes it sound like the patient's not going to get anything. So we don't talk about removing care. Patients always get care. "There's nothing we can do." Oh, that's a terrible statement. There's always something we can do. They may not like what we can do because what they want us to do is return them to their prior state of health and offer them cure. We can always support. We can always care. We always provide treatments and medications and symptom management. But sometimes cure just isn't possible anymore. "I know what you're feeling." It is possible, but it's not likely. No two people have the same journey. We need to ask permission to provide similar situations if we think it might be applicable. "You're a fighter, not a quitter." When that statement's said, that can be a terrible statement, as it may imply their worst fear, that they can't choose comfort because someone may not appreciate their situation and may feel like they gave up. I recently had a patient during a complex goals of care discussion tell me a Shakespeare quote when I asked him about his life-sustaining preferences. And he said, "Cowards die many times before their death. The valiant never taste death but once. I want to die just one time. I'll have the hero's death." And after telling me and the family that, his family all supported his choice for comfort-focused care to make every day the best day for as long as the days continued to come. Another statement that we don't want people to misinterpret is that you're fine. That's not true. They're not. We use the acronym NURSE, N-U-R-S-E, for a lot of statements that we commonly use. N for naming. Let me name the emotion that the patient has. U is understanding and empathy, acknowledging the difficult conversation. R is respecting, recognizing, and validating for coping strategies, telling them that they are doing an amazing job and they've done an amazing job to get to here. Supporting the patient and their family. E is exploring their feelings and encouraging them to express thoughts and feelings. So we use a lot of these common statements to help acknowledge and validate their emotions, such as, this is difficult to hear. This must be very upsetting. What I'm hearing you say is, it sounds like you're feeling. This must be hard to process. What I'm really worried about is, information that I need to share today is very worrisome. We need to discuss some upsetting results. I want to help support you through this. I have information I need to share, and I want to learn your thoughts. Let me know your thoughts on what concerns come to your mind right now. I want to offer ways that can help. Healthcare professionals can participate in training programs from multiple sources, and I'll give you a few examples of those. Vital Talk is an international program that offers mastering tough conversations. Communication Skills Learning Pathways by Center to Advance Palliative Care. Crucial Conversations for Healthcare. Program for Excellence in Patient-Centered Communication from Academy of Communication. Effective Communication in Healthcare, and that's Mayo Clinic. Empathy and Relational Science Program, which offers online courses. So there are a lot of different training programs, but it takes time and practice. Difficult discussions are about exchanging information with patients. We learn from them about what's important to them, and they learn from us about their disease process, stage, and trajectory. They tell us who we are, and we provide them with information about their state of health. We fill in gaps about outcomes, procedures, and treatments. They tell us if the prognosis after the intervention is acceptable. Working together, we design a unique plan. The stakes are high, and each situation presents its own challenge. We learn the patient's hopes and we address their fears. We ask open-ended questions and learn about the person that has the illness. We make suggestions to help find out what's available for them that they will accept. When they need help, we try to find that help for them. Patients tell us what they find acceptable. We are mindful of the words and body language and vocal tone. We try to maintain eye contact. We want to use a calm, reassuring tone while controlling our speaking speed and volume. We use smooth and reassuring gestures. The medical team is responsible at each change in condition to provide the necessary updates of information that patients and families need to make their decisions. Patients can be unaware that they have serious health issues, and if we don't tell them, that's on us. Patients could easily fall into the trap of no news is good news, and they rely on us to be their guide through healthcare. Patients need information to be able to adjust their choices and make their decisions. It's their decision to make because it is their health. As their health changes, their goals and hopes will also change. People need the opportunity to consider the choices that they have and the outcomes so that they can make the decisions that are right for them. We support patients in their journey, and we're not going to abandon or desert them. We never run out of options. There's always something that can be done. Learning about a person and how they live their life gives us insight into how we can best help them when they have serious illness. Being able to appropriately offer care, interventions, and services that can assist to help them live better is made possible by having these difficult conversations. Discussions that share information provide patients and their families the ability to achieve their goals because they've set the goals themselves, and that gives them a higher quality of life. Thank you for being here again. We appreciate your kind comments. They're always welcome. Bye now.